Hello everyone, welcome back. It's been a while since we've done an EMG case, so let's get started. These are fun because we go through the case, I present the data first, and we work backwards with differential diagnosis to try and build your clinical acumen. So here we go. We start out with sensory nerve conduction studies, and right off the bat, medial and lateral antebrachiocutaneous sensory. What are we thinking of in terms of what could be the pathology? Same thing with motor. We're going with axillary, spinal accessory, and suprascapular motor. So just looking at that, you see someone that comes in, what's on your mind? What's going through your head? This is the waveforms, pretty much standard fare. So let's build this out, right? What is your differential? Medial and lateral antebrachiocutaneous sensory, my first thought, yeah, it could be a plexopathy case. Maybe there's something going on there, a traction injury to their brachial plexus. Could this be a shoulder pain case? Some patient had a shoulder injury and they're worried about it. Maybe it's a proximal weakness case. Maybe it's one of those myopathies and we're just trying to get some proximal data going. Could it be winging of the scapula, right? Start to expand your mind here. It could be, not exactly sure, but it could be. Further expanding your thoughts here on differential, could this be a Parsonage-Turner case? Yeah, very, very possible in this situation. However, all things, in my opinion, are pointing to something going wrong with, let's get the pointer going here, there. Somewhere along this pathway, at least upstairs in the brachial plexus, or even maybe a cervical radic, like a C5-6, or somewhere along this pathway down the shoulder. So here is our EMG, and everything's pretty much normal. Now, without knowledge of the case history and exam, what are we looking at? To me, all right, you've clearly looked at some C5-6 stuff, axillary, suprascapular, upper trunk brachial plexopathy with lateral antebrachiocutaneous sensory more than medial, that would be CAT1. Parsonage-Turner, yeah, it's got to be in the differential of anyone. Shoulder dislocation, maybe the patient had a dislocated shoulder, they're having a lot of pain, they can't lift their shoulder, somebody's worried that something happened. By the way, if you're thinking about a shoulder dislocation and an axillary neuropathy, we do nerve conduction to axillary motor all the time. Nerve conduction to teres minor, very hard to do, not routinely done. Maybe this is a structural mechanical issue in the shoulder, spinal glenoid notch cyst. That would really be infraspinatus involved, so you'd want to do supraspinatus and infraspinatus, check those nerve conductions. Maybe it's something higher up, suprascapular neuropathy as well. That's common in overhead athletes that get a lot of traction to their shoulder, such as baseball and overhead throwing motions. Swimming can do it too. So that's what we're looking at. Now, data says, however, nerve conductions, normal. EMG, normal. Clearly, the ordering clinician, your referring provider wants some answers on what's going on. So what do we move to in this case? Yeah, you named it. We got to dial this in. We got to dig back into our nerve conduction. Should we do another nerve conduction? Should we do a different muscle? And yes, I kind of withheld something from you. We did the teres minor, not commonly done, and it was clearly positive. There was something wrong with that teres minor. So I just deleted that from the first part of the case just to help build your mind and think it out. So what's going on with the teres minor? It is right there, that little muscle right there. If you have a well-muscled individual with little body fat, you can actually see it, the muscle belly right there between infraspinatus, teres major, long head triceps and lats are right there, posterior deltoid. Or right here. I like this one because we can overlay all these. So infraspinatus here, if you're sticking a needle in on needle EMG, your target entry is 3 centimeters lateral from the medial border of the scapula at about 2/3 of the way down the medial border of the scapula. Teres major would be going to the inferior tip of the scapula and about 2 centimeters up. If you go much higher, you might be in teres minor. If you go lower, you're going to be in teres major. Major. You can overlay these right here on the left, 1, 2, and 3, to see where this kind of triangulation is of needle EMG. Surprisingly, these are a lot closer together than they look on the screen. This can be a hard muscle to get with EMG. Here's a little review of teres minor. You can pause it and review that on the screen for your info. So now what do we do? Well, as I usually do in this situation, got to move to the ultrasound. So here we go, ultrasound of the deltoid. So clearly no loss in muscle bulk, no hyperechoic signal of the deltoid, very normal appearing. So deltoid, check. Upper trapezius and supraspinatus, often we use the trapezius as a reference mark when we're looking at supraspinatus to see if there's atrophy or hyperechoic signal. Nothing doing there. Not suprascapular neuropathy, check. Move on to this next view, which gets a little trickier trying to position these, but you got deltoid here, you got the infraspinatus muscle belly, and teres minor muscle belly, and now wait a minute. Something's going on. Infraspinatus looks nice and dark and hypoechoic, like normal muscle should. Teres minor, not so much. Here's another view looking at that as well, and clearly there is something going on. And sometimes the only way you can see that is by putting a sample or reference muscles next to it and comparing the echo texture. This one's my favorite. It's kind of hard to do, but if you get infraspinatus right here, teres major right there, and then lowercase here, teres minor, now you really can see that difference going on. Neat thing about this, these are all C5-6 innervated muscles. You can also check that box, not really a C5-6 redic, because if it was so bad that it's causing atrophy with teres minor, you should see some signal change in the other C5-6 innervated muscles. The way to do this one is you got to just kind of get an angle where you have part of the infraspinatus, part of the teres minor, part of the teres major. So you kind of take a cross section just straight across there. This one was a fun one. Once I had this diagnosis, I loved this image. Take deltoid and teres minor, and now it's really clear. So now some people say, wait a minute, this could be an axillary neuropathy. Deltoid should be involved. Well, clearly it's not based on the ultrasound. This one, you got to get the posterior deltoid and the teres minor, so you're just taking an image just right across here. Not enough to hit teres major and not enough to hit infraspinatus. You just want to get this little section right there. So now let's go backwards into the history. What is going on in this patient? Well, 29-year-old male, no trauma, insidious onset of shoulder pain for about a year. So this has been bothering him chronically. Does a lot of working out, a lot of weightlifting, was having pain in the posterior shoulder, was worried about something, so came in and got it checked out. Specifically, when it really hit the fan, he was doing a dumbbell press when it hit him. So that typical, see if I can get my arm in the view here, 90 degrees abduction, 90 degrees of external rotation, that typical 90-90 position, whether you're pushing a dumbbell overhead or throwing a baseball, you're going to get that symptomatology. FYI, had some pain golfing. That was anterior shoulder, so he was having some symptoms both posteriorly and anteriorly. Pickleball as well, same thing, depending on the motion that you're doing. A lot of internal and external rotation with pickleball, especially if you're doing the smash. Tried some therapy. Of course, it didn't help, so ended up in our world. Physical exam was actually very normal. That's a key point here. No real tenderness when you're palpating the back of that shoulder. Couldn't really find anything. Range of motion, strength, just leave it at that. It's normal. No altered sensation in the lateral shoulder. So if you're starting to think about axillary neuropathy, you'd expect to get a patch of numbness there. If it was like a shoulder dislocation case and you expected a traction axillary neuropathy. Did have some irritability with O'Brien's and some other labral testing. So now we're starting to think, well, maybe it's a labral tear case here. Test results. So again, the lateral antebrachiocutaneous was normal, no real superior trunk or parsonage Turner. Very commonly, biceps and lateral antebrachiocutaneous are involved in parsonage Turner, so make sure you check those if you want to rule those out. All these CMAPs were normal. C5-6 EMG was normal, including the deltoid, so it's not a C5-6 redic. So this is what actually happened in the case. I did the routine EMG, which we all do, which does not include the teres minor. Went to the ultrasound looking for more answers, saw the obvious difference in the teres minor, and then told the patient, look, can we go back and do the EMG? We need to check that teres minor. And got it, and it was so clearly positive. So this is the tricky thing about this case and this condition. If you don't do the teres minor, you're not going to see it. So either you include the teres minor on all your screening, which is hard to do, or simply grab that ultrasound. It's often sitting right there in your office and start using it. So push the case forward, we eventually get an MRI. There is a posterior labral tear and a paralabral cyst, so that might have accounted for some of those labral signs on physical exam, maybe some of that pain with golfing. It was in the posterior area. The cyst did not compress the suprascapular nerve. I have an image of that later. There was fatty atrophy of the teres minor, perhaps no surprise here, and that's what we're dealing with. Now, let's dive in to this MRI. So this is a T2 MRI. This is the Y view right here. So the scapula right there. Supraspinatus here. Subscapularis here. Infraspinatus here. Where the heck is that teres minor atrophy? We go to T2 all the time looking for abnormal signal. That's where the pathology is. Well, in this case, you got to go to the T1. So here, supraspinatus here, very normal, subscap here, infraspinatus here. That's it right there. And when you line them up all together as you're scrolling through 1, 2, and 3, now you can really see that difference. That muscle is not healthy. That is atrophied. It's marbled. There's a lot of scar tissue, fatty infiltration. Not a healthy looking muscle like the supraspinatus. So T1 is your friend. Make sure you look at them. By the way, here's that cyst near and around the infraspinatus, but clearly not affecting the infraspinatus. That signal is completely normal. There's no pressure on the suprascapular nerve. So what is this a case of? And FYI, I have a companion case coming up in a future video. We're going to go into this more, but this is quadrilateral space syndrome, sometimes called quadrangular space syndrome. Very common cause of posterior shoulder pain that goes missed or underdiagnosed or misdiagnosed. It's kind of insidious onset, no real trauma, no real findings on physical exam. The deltoid is completely fine. You often miss it if you're not really looking out for it. So again, physical exam is usually normal. The problem's back here, but it's just not picked up. It's a vague pain in the posterior shoulder, overhead athlete. So if you're thinking about it on your history, you can be aware of it. You don't really get any sensory issues. So again, physical exam is going to be pretty normal. No weakness. Physical exam is normal. EMG, if you don't do the teres minor, EMG is going to be normal. So I get it a lot only because once you do enough EMG, you start looking out for it. And if you have the ultrasound, you can quickly scan that teres minor, and then you can get a lot more answers. And I've started to incorporate a little more needle EMG of the teres minor in my practice as a result of this, but sometimes I'll often go to the ultrasound first. There is a physical exam maneuver described regarding the teres minor. It's been called the hornblower's test, but it's not great. It's really for a teres minor tear and how it was originally described, not really for atrophy and weakness. But this, if you want to know, the French horn, the hornblower sign, they hold their arm, kind of one arm up and one arm down. So the physical exam, this is the classic one that is often used in a lot of presentations. When you have that patient up with their arm out and you have them resist external rotation, their arm just buckles down and drops down like it's drawn in this picture. They just brought the other arm up to kind of pretend like you're holding a French horn, I guess. But they cannot externally rotate against resistance with their arm abducted and actually in the scapular plane. So not exactly in full-on abduction. You got to bring it about 30 degrees forward in horizontal adduction and then have that arm up, and then they cannot resist that external rotation. It's a recently described diagnosis. In 1983 is when it was first started to be reported, but it's been around for a while. It involves compression of not only the axillary nerve, but also the posterior humeral circumflex artery in that quadrangular or quadrilateral space. Many times it goes misdiagnosed as a variety of different things. True quadrilateral space syndrome is actually in very younger athlete populations. 20 to 40 is kind of the classic. So not really people looking like this, people looking like this. This is more the teres minor tear, which is also kind of rare actually. It's perhaps no surprise, more common in the dominant shoulder, and the risk factors are obviously doing a lot of overhead work. Doesn't have to be sports, could be people, painting or doing overhead activities as well. Throwing sports, of course. So basically, people like this. So there you go. Hope you enjoyed it. Kind of a neat case of posterior shoulder pain, quadrilateral space syndrome. I do have a companion case that I'm going to release in a subsequent video going into this in a little bit more detail, so look out for that. And hopefully I'll start to put up some more of these EMG cases because they are a lot of fun. I enjoy being kind of a detective, doing my detective work like that, trying to figure out what's going on in these cases. All right, see you in the next video.